Remember what it is? Beggar's disease. The last time, if I remember very well, I spoke about Beggar's disease and the cardiovascular system. And I said it was a peripheral vascular disease, Beggar's and Raynaud's disease. So Beggar's disease affects your hands and your feet. And mainly it causes obstruction and inflammation of the blood vessels to your hands and to your feet. So that's what Beggar's disease is. It's a vascular disease. And you will see that mostly it affects your hands and your feet. So it's under cardiovascular system. So with clients who have Beggar's disease, they will have symptoms of pale, blue, cold hands and feet. And they may also have tingling, or they'll complain of having pain. So the treatment goal for this is that there is no actual cure for Beggar's disease, only that you can control the symptoms. So you teach the client to stop smoking. So for clients who smoke a lot, they are more of a risk. So you teach them to stop smoking and to dress appropriately for cold weather. So, and they also need to try to reduce stress. So stress can also cause that. So that's it about Beggar's disease. That's what you need to know. You need to know that it's inflammation. It's inflammation or an obstruction to the hands and to the blood vessels in the hands and in the feet. And it causes pain. The hands will look pale as if there's no blood supply to them. If you have ever been in the cold weather, you will see what that is. I think I spoke about that in cardiovascular system. When we spoke about cardiovascular system, I spoke about Beggar's disease. So the last time I stopped at cataract. So today I'm going to continue. I stopped at celiac disease rather. I'm going to go with cerebrovascular accident, CVA, stroke, CVA. So what is stroke? So CVA or stroke is reduction of cerebral blood flow, reduction of blood flow to your cerebrum in the brain, and oxygen that causes brain damage, or that causes damage to the brain cells. That's what CVA is. So we have embolism as a cause of CVA, we have thrombus as a cause of CVA, and we have bleeding. If you remember, we have transient ischemic attack, and we have the hemorrhagic one. So we have the signs of a stroke that a patient will present to you. The patient will complain of headache. They will say, I have a severe headache. And they will also complain of nausea. And they will say they have their blood pressure. They will have hypertension, slow bounding pulse. The pulse will be slow and it will be bouncing. Then they will have giant strokes, respiration, and speech changes with facial droop. Most often they will tell you, you see their face going to one side and they are like slurring. Their speech is not clear. They will have slur speech. So if you know what slur speech is, the person is speaking out, but the words are not coming out. And you see their face droop on one side, their mouth will be turned one side. Do not confuse stroke with, don't confuse stroke with the other condition I spoke about last time, Bell's palsy. Don't confuse stroke with Bell's palsy. The complaint that will come with Bell's palsy, the person will complain of headache, and then it's the facial nerve that is affected in the case of Bell's palsy. So the person will say the pain is around the jaw or behind the ear. The pain will be located one side, and that one, they sleep with one eye open. The side that is affected, they will have one eye open when they go to sleep. So the difference, we have the different types of CVA. So we have the transient ischemic attack, which is a period of neurological deficit. And it has similar signs with CVA, but the symptoms will all resolve. So we have transient ischemic attack. So the transient ischemic attack appears with similar signs and symptoms like that of the CVA, But with that one, the symptoms do go away with time. So they will have inability, a patient who has stroke will have inability to correctly identify the object. Sometimes they don't even remember their own date of birth, or they don't even remember their own name. It depends on how much or how long the person have waited at home to come. So they will have expressive aphasia. And this one occurs where the client cannot properly communicate. Like I said, they will have aphasia. They cannot properly communicate. And aphasia can be expressive or receptive. Expressive or receptive. So if the right hemisphere is affected, you will see weakness on the right side. If the left, so if I have the left hemisphere of my brain affected, I will have weakness to my right side. So if the left side is affected, I will have weakness to my right side. So remember that the client belonging, usually it's opposite. So if this side is affected, you see a patient and the facial droop goes this way. That tells you that the impact is on this side. So the mouth has drooped on this side. That's affected the nerves on this side of the body. So you remember to place the client on the unaffected side. That's the positioning. So for a client who has stroke, you have to place them on the unaffected side. Don't place them on the affected side. So if the client has a stroke on the right side, you place them on the left side. The test that they use to determine CVA, they will do CAT scan. You also do an EKG. You see cardiovascular system changes on the EKG. And then they will do cerebral angiogram. They will assess the brain compartments to see where the bleeding is actually coming from. Sometimes they go further to do MRI, but mostly for LPN, you just need to know CT scan, and you need to know the brain angiography that they do, the cerebral one, to see the brain compartment. They will not take you deeper to MRI. So for patients who have hemorrhagic stroke, we have those that we have two types of stroke. We have hemorrhagic, and we have the one that is as a result of a blood clot, the one that is as a result of blood clot. So hemorrhagic is when there is bleeding in the brain, and the one that is as a result of thrombus formation that blocks blood supply to other parts of the brain. So seizure. So for the patient that has the hemorrhagic stroke, they are at increased risk for complications, and their complications can be seizure because of the bleeding in the cortex of the brain. So the nursing assessment that you will do is to monitor their vital signs, and you do a neurological check. Vital signs, neurological check, and then you watch for seizure as well. Since their complication can be seizure, you want to watch, and then you check their ability to swallow. Since they're going to have difficulty expressing themselves, difficulty communicating, you want to monitor them for communication challenges, and you want to monitor them for swallowing difficulty as well. So the complication of the eyes, when a client with CVA, they have corneal abrasion. They have corneal abrasion. Remember, you see the eye too, it will not. So if this side of the brain is affected, this whole side of the body is affected. So for the sake of the LPN, one thing you want to know is neglect of the body part syndrome. Sometimes they forget of one side of their body. So just take notice of that. So with the activity level at the initial phase, you want to have them on strict bed rest. You don't want them out and moving about, and there's a problem in the brain. They cannot coordinate well. They will have problem coordinating. Sometimes they're not even able to walk. So they have ambulatory challenges. So you maintain them at bed rest to prevent falls. So you position the client, you turn them every 2 hours. If you maintain a client on bed rest, most patients that go on bed rest, not only for stroke, but most patients that are on bed rest, you want to have them for every 2 hours turning schedule. So for every 2 hours, you want to turn them unless otherwise indicated. Sometimes we have facility protocol that come into play, so take notice. And to manage patients with CVA, usually they do a procedure. They do a procedure to declot, to declot the clot. If it's like the blood clot one, they do a procedure to remove the clot. That's why they rush them to the cath lab to have them taken care of. So if a patient has a clot in the brain, they take them to have it declogged. If a patient is having stroke due to hemorrhage, you want to give them anticoagulants to help stop the bleeding. That's how you manage it. But mostly, the other medications they can also prescribe for the stroke patient are hypertensive medication, usually hypertensive medication and anticoagulant for those with the bleed in the head. So take note of the neglect, the body neglect, that they forget one side of their body. They forget that this side of my body is supposed to be used. So they just keep using one side. That's why you incorporate exercise. So you want to teach them, you want to try to teach the family. Mostly if the person is able, it depends on the severity of the stroke. Sometimes the person can be a little helpful, and then they take them to rehabilitation units and help them with rehab and physical therapies. And if ambulatory function comes back to normal, that's it, is good. So your aim for taking care of a stroke patient is to have them as much independent as possible. Your aim for nursing these patients on the NCLEX is not to have them stay in bed. So have it in mind when you are answering questions. Don't answer questions that will keep the patient in bed forever. Remember, discharge planning starts immediately from admission. So every time you have a patient, and I will always tell you this, when you go on the NCLEX or even the weekly exam that you get, all the questions that you get are questions that are similar that NCLEX will present to you. And when you have each question, you start reading. So let's say I'm answering it and I go to question number 5. Question number 5, the question that appeared to me is assume that I am the nurse for this patient. Don't assume you are a student. Don't assume you don't have license. They assume this is what you should be doing. So I am the nurse for this patient. So mostly you'll see that the questions will frame that the nurse is caring for so and so. So put yourself in that shoe. You are the one caring for this patient. So why will you take this action? So when you are answering the answer options, you want to ask yourself this question: why will I take this answer option first? They want to know what I will do next. After this one was done, after the patient have done this and that, what will I do next? So your question should be that you ask your own self. I cannot ask that for you. You have to ask yourself, why will I do this next? Do I understand what a stroke patient would want? All they want is to be able to get back to normal function. So the patient have lost brain function. They are not able to ambulate. They are not able to talk. They have problems swallowing. They have memory challenges, walking difficulties. So activities of daily living is a problem. So you are trying to help them as much as possible to have them to be independent. So if another teaching you want to teach, or you want to nurse this patient, you want to pick answer options that you are providing care towards recovery. You are not just picking options that will make you keep the patient in the facility forever. Activities of daily living is crucial. So you are teaching the patient. It's like you have to teach them all over again. They need to relearn to live their lives. That's the number one priority for the stroke patients. They come back and they become like students. They become like children. You have to teach them to be able to get back to life. So you just don't assume this is an elderly patient and then you continue with whatever you want to do. You have to teach them how to eat, how to talk. You have to teach them how to dress up, because they are now struggling. One side is not working well. Teach them how to dress. Ambulation, that's why you get physical therapy involved. It's a multidisciplinary team, but the nurse or the LPN, you are involved in the care. They will always look for you. Now let's talk about COPD. COPD. So we all know COPD. We all know that the disorder types of COPD, most patients who have COPD, they are asthmatics. Asthmatics are at higher risk for getting COPD, and patients who have bronchitis and emphysema, they are the three disorders that can make up COPD. They are the three disorders that come together to form COPD. So COPD is as a result of a patient being asthmatic, a patient having bronchitis, inflammation of the bronchioles, and then the patient having emphysema. So those are the three disorders that form chronic obstructive pulmonary disorder. So the signs and symptoms, they will always be short of breath, they'll be wheezing, productive cough, and they become cyanotic. You would want to monitor them for hypoxia. Patients who are COPD, you monitor them for their oxygen level. So the oxygen level is usually the hypoxia level of every patient. Anytime they talk of hypoxia, you want to start thinking in the labs. When you think about the lab result, you're going to think about ABG, arterial blood gases. That's where you see the CO2, the carbon dioxide level in the patient. So you want to think CO2, ABG. That is done through ABG, arterial blood gases. So remember the last time I told you arterial blood gases, you draw the blood from here. You draw the blood from here for arterial blood gases. So the client who has COPD will have a barrel chest. They will also have a barrel chest, and they have clapped fingers. Their fingers, they will also have clapped fingers, and they have weight loss. Weight loss is a concern. And this is because they are always short of breath and they have activities intolerance. They have activity intolerance, shortness of breath, so they will lose weight. You are always concerned. They are preoccupied. Their minds are preoccupied. So it is necessary for you to assess the amount of their oxygen level when you have a COPD client. So you have to check them for breathing, and then you check their CO2 in their blood as well. So you have the question present to you that a client come to the hospital and the client is short of breath. You check the oxygen saturation level is 92 or 91. And the client tells you they have chest pain, but they appear to be comfortable. They are comfortable. The client is not kind of in any distress, but the client tells you, I have chest pain and I'm short of breath. But from your physical view of this client, they are sitting down. It's not like something they are struggling, but you see that their chest is barrel and they are kind of not like a normal chest will look. So the next question you want to ask them, or even if you see them on oxygen, you see somebody on the street on oxygen, the first question you always want to have is, do you have a history of COPD? Do you have a history of COPD? And mostly it will come with people that smoke. So the standard oxygen you want to put on this patient is 2 liters per minute. 2 liters, it should not exceed 3 liters per minute for a patient who has a history of COPD under your care. So never pick an answer choice that will say you administer 5 liters of oxygen to the patient they are talking about on the exam that has a history of COPD. So that is to control the breathing techniques. You also have to help them to do a pursed lip breathing exercise. You have to teach them to do a pursed lip breathing to have them breathe in enough oxygen, and then they purse the lip, their mouth, they close their mouth, and then they breathe out. They hold in the breath and then they breathe out. You want to be able to help them take in enough oxygen and have the lungs expand well before they breathe out. Most of them will also have a history of smoking. So in case they present to you a question and they're describing a patient and they tell you the smoking history, if they tell you the patient's smoke history, you want to also question if there will be a history of COPD based on the symptoms that will be presented to you. Now, let me just chip this in. The NCLEX is not something that you say, I hear a lot of people saying they're having questions and they are given, the questions are from the NCBSN, and people think that you pay for those questions and you go there and sit down and get it. It's a fallacy because the exam tests you based on your ability to answer the previous question. So the next question you get is a question that is thrown to you because you answered this question, and this question was an analysis question. So they know that your level, you are good to pass. So they throw in questions that are more for you to analyze. But when you start getting wrong, they start throwing questions that are straightforward content for you to understand. So they want to ask you, a patient who has stroke, what are the symptoms you will see in the patient? And they put facial droop. This is a pretty cheap question. They have not twisted it, but they use the same question and they frame it to trick your mind to see if you are able to understand that this is about stroke. We want you to answer the question from. So take note when you are answering questions. Take note when you are studying. Don't just study because you just want to learn and know. You have to be able to use this knowledge to critically maneuver your way to understand the content, because they use the content to frame it just to trick your mind to see if I change this, if I change my name right now and I appear to you, will you be able to recognize me? That's what you need to think. So if I take a disease condition like COPD and I change the patient's name, or I change the patient's oxygen amount, and I say the patient is getting 1 liter per minute, or the patient is getting 5 liters per minute, will you be able to understand that a COPD patient should get at least up to 3 liters per minute? You have to be able to figure these things out, and that's where you'll be able to help yourself. So you take them to do the pursed lip breathing exercise for the COPD patient. And remember, you have to give them medications as well to help them with the breathing first. Remember, the COPD, I had mentioned that it's made up of asthma, emphysema, and bronchitis. So these ones will cause wheezing, the patient will be wheezing. So you want to give them your steroid. You start with bronchodilators, things that will dilate the airway for them to be able to breathe. So now I'm going to talk about corticosteroid. So corticosteroid, we know they all end in, we know it. When you see corticosteroid, prednisone, they all end in O-N-E, most of them. I think I did send some pharmacology to some of you, but I haven't finished that yet. I have more of those medications to send out to you. It's not everybody who received it. I sent it to some people today. Try and go over it. I do feel like it's a summarized version of the pharmacology you need to know. And I have pregnancy categories under each of the medications that I sent. Let me know if you don't understand the pregnancy categories, because we have pregnancy category A, B, C, and X, D, and X. So each of the categories have at which stage of pregnancy a lady can take that medication. So let me know if you are able to go over that material. So most corticosteroids will end in O-N-E, okay? Prednisone, dexamethasone, cortisone. Those are corticosteroids. So they are used to decrease inflammation, and they are also used as a hormone replacement in patients who have problems with steroid in their system. So what should you teach a patient about gradually stopping corticosteroids? So if I have been taking prednisone, if I got sick and the doctor put me on prednisone, and then I walk up to you and I said, oh, when I started taking this medication, I realized I was gaining too much weight. So I didn't take the medication. Last week I just took it for 2 days, and today it's been like 8 days now. I don't think I need to take that medication. When a patient says that, that means the patient needs further teachings. So you tell them they should not, they should gradually decrease the use of the medication and not to stop taking it once, not to abruptly stop taking corticosteroid, because if they abruptly stop, they're going to get a rebound effect. So you have to monitor the client that is taking steroid. You have to monitor their potassium level. You have to monitor their glucose level. You have to monitor their oxygen level. So for clients that get steroid, they tend to develop some form of high glucose levels. Somebody will tell you, I started taking corticosteroid and I was diagnosed as a diabetic. I think I have diabetes. So for clients, it's a predisposing factor to causing diabetes in people. So you want to take notice. So they also may cause symptoms like Cushing's syndrome. That's where the person gain abnormal weight. You start gaining weight. I think I discussed that under physiological integrity. I went into these syndromes into details with the physiological integrity. So when you get those videos, please take your time and go over that. So I have corticosteroids that also will cause delayed wound healing. Corticosteroids, it will also delay wound healing. So if you have a wound, it's not going to heal on time. So for patients who are taking steroid or who are taking corticosteroid, if they have to go for surgery, you want to maintain them on NPO. You want to maintain those patients. Or for clients who are NPO for surgery, they can still be given. You can still give them corticosteroid, because during the surgery, there will be stress, illness in the body, and this one will increase the need for steroid use. So for people who are NPO, they can take steroid. They can take corticosteroid, even though they are NPO. But if the doctor order corticosteroid, you have to give them, because after the surgery or during the surgical process, they'll have an increased need for corticosteroid. So in all of this situation, you tell them not to take the steroid, and you do not also take a steroid on empty stomach, okay? That's the funny thing. So if a patient is going for surgery in the next 5 hours and they say, we want this patient on NPO, there's still some amount of food in the patient can take steroid, and then the patient don't eat before they go in for the surgery. Now let's talk about cranial nerves. I don't know who has looked at this before, but I'm going to jump into cranial nerves. Please, are you all staying with me? Are you listening? Are we participating? Are we understanding? Are we taking notes?
Yes.
Yeah.
Yes. It looks like I'm a little fast. I understand. But I know it's going to be recorded, so you can always go back to listen to these videos. It's a review that will help you just remember some of your content material to answer questions. Let's talk about cranial nerves. Cranial nerves. If you can draw a table for me, just draw a table. This is one of my favorite books, so I don't like to draw inside. But just draw a table for me, a big table, and then you divide it. I just need 2 boxes on that table. It's cranial nerve 1, 2, 3, 5, 4, 5, up to 12. So cranial nerve 1, what is it? It is the olfactory nerve, and it controls the sense of smell. Cranial nerve 1, olfactory nerve, control the sense of smell. That's the one that controls smelling in your nose. Nerve 2 is optic nerve. Nerve 2 is optic nerve. I know people have a lot of acronyms for this, but sometimes it's just easier to know where the nerve is supposed to be located, and you are fine. So if I know nose is olfactory, eyes is optic, I'm done. It controls vision. I'm able to see. If this is affected, I'm not able to see. So the optic nerve is your cranial nerve 2. So number 1 is the nose. Number 2 is the eyes. Number 3, oculomotor. Cranial nerve 3 is oculomotor, that control eye movement. I'm able to roll my eye like this, and I'm able to blink my eye. I'm able to eye you proper. So it's not only that cranial nerve, but it works as a team. So I have cranial nerve 3, cranial nerve 4, and cranial nerve 6. 3, 4, 6. No, is that 6? Yes. 3, 4, 6. Cranial nerve 3, 4, and 6. They control eye movement. So 3 nerves control the movement of the eye. So I'm able to bend my eye laterally. I'm able to look up. I'm able to look down. You are able to look on the side. So you remember the eye has the eyeball in it and the retina, and they all keep switching their movement based on how you control them. So there's a nerve in your cranium that controls that particular movement. It controls which side your eye go. And that is cranial nerve 3, 4. Is that 4? Yes. Cranial nerve 3, 4, and 5. So one is the trochlea and abducens. The trochlea and abducens. Please, I'm going to type this one. Maybe somebody can help me with the Roman numbers. I'm not an expert when it comes to Roman numbers, okay? So pardon me for that. I'm not a Roman numbers girl. Let me not make a mistake by giving you the wrong Roman number. Okay. Is my screen being shared or we cannot see it? Can we see my screen?
Yes.
Yeah, I can see your screen.
You can see the Microsoft thing I put there?
Yes.
Okay. So I have this one that I'm sure is 3. Then I have IV, and I have VI. So these are the cranial nerves I'm talking about. So if someone is good at the cranial nerves, you can help me out. I said this is cranial nerve 3. That's the oculomotor nerve. Oculomotor nerve. And this one is the cranial nerve 4, the trochlea. That's the trochlea nerve. And this one is nerve 6, and is the abducens. Abducens nerve. So these are the cranial nerves that control the movement of your eye. Do we get it? Did I mention the Roman numbers correct? 3, 4, and 6. Are you with me?
Yes.
Okay. So they all control eye movement. They control the eyeball moving up and around. Now let's talk about the trigeminal nerve. Trigeminal nerve. That's cranial nerve 5. That's V. Cranial nerve 5. Trigeminal nerve. And that one controls the sensation of the face. Sensation of your face. That's the trigeminal nerve. So when a patient has stroke and they're having facial droop and they cannot feel one side of their face, that means that nerve has been affected. Now let's talk about cranial nerve 7. Nerve 7. So this one is trigeminal nerve. Cranial nerve 7. 7 is VII. And that one is now the facial nerve. Facial nerve. That's the one that controls facial expression. Facial expression. So if I look at you, I'm like, I squeeze my face. That's the word I want to use. Squeeze your face instead of frown. So frown your face. That's the nerve that controls frowning of your face. Now the cranial nerve 8, nerve 8 will control your hearing and balance. That's the acoustic nerve. Acoustic nerve. It controls your hearing and your balance. So you hear sound like this, you're able to trace to know where the sound is coming from. Now, cranial, which one is this? That's the glossopharyngeal nerve. That's the glossopharyngeal nerve, the one that controls the tongue. I think that is 8, right? Is that cranial nerve 8? I'm not good in Roman numbers. Glossopharyngeal.
That's 9.
That's 9, right?
Yeah.
Okay. Pharyngeal nerve. It controls the tongue movement. It controls the gag reflex and swallowing. This is glosso. Glosso means the tongue, the larynx, which is through down there, and then swallowing. So it controls gag reflex and swallowing. Your ability to be able to identify that food is going through your respiratory system and you start coughing. The gag reflex and the swallowing reflex, it controls that. So you see that when you are drinking water, you are eating something, it accidentally go the wrong way, you start coughing. So the gag reflex, or when you put something on your tongue, if I put this pen down to the back of my tongue, you see me start gasping. So that's the gag reflex. Then we have the next one, that's the vagus nerve. I think that's 10. X is 10. So we have the vagus nerve, that's the gag reflex and parasympathetic nerve. It controls gag reflex and parasympathetic nerve. And then the 11th one, that's the XI, is the spinal nerve. Spinal nerve. We know what this one would do. Your back and your neck muscles, keep them in place. So this one was the vagus nerve. And the last one will be the hypoglossal. Hypoglossal. That is cranial nerve 12. Nerve 12. It controls your tongue movement. So if you look at cranial nerve 9, 9 and 10, 9 and 12, they work on the tongue. They work in pairs. They are on the tongue. Then you look at cranial nerve, the trigeminal nerve and the trigeminal nerve and the acoustic nerve, right? What is the yes. You look at these two, they are on the face. They control the facial movements. Then you look at the past 3, the up 3 that I typed, 1, 2, 3, they all control eye movement. So just understand them based on their location. So you know that the one that controls your back muscles, your back and then your neck muscles, the muscles in your back that keep you erect and that keep your posture right is your spinal nerve, spinal accessory nerve. So let's continue. So the client is unable to shrug his shoulders, which nerve will be dysfunctional. So if I'm not able to move my nerves, my shoulders like this, I don't know who is watching, but if I'm not able to do this, so which nerve do you think will have the problem? If they come to you with a question and they ask you, the client complained that they have not been able to move their shoulders, which nerve will be affected? I just mentioned that. So cranial nerve 11 is the spinal accessory nerve. You are concerned that that nerve is affected. So if you're unable to smell, your nose, olfactory nerve has the problem. And if you are not able to distinguish between salty and sweet taste, and the nerve that will be dysfunctional is the facial nerve. If you are not able to distinguish between taste, the facial nerve control your tasting buds, control your ability to taste. So that is it for the nerves. Let's talk about Crohn's disease. I'm going to move on to Crohn's disease. Can I move on?
Yes.
So Crohn's disease is inflammation of the bowels. Inflammation disease of the bowels. It affects the bowels. Your bowel is a GI problem. It can be cured, but it's not like something that will go completely. So Crohn's disease, we don't do surgery for that. There is no need for surgery. The symptoms will always reoccur. You can control the symptoms to be healthy and to live fine, but you cannot do surgery with Crohn's disease. So if your bowels are inflamed, you can only do with dietary most of the time. So in Crohn's disease, the digestive tract, which is the mouth down to the anus, is affected. So from your mouth down through your anus. That's when you look at the picture of the digestive system, the digestive tract, your whole system is affected. I'm gonna get a picture. So there will be excessive diarrhea, which causes electrolyte imbalance. So the patient will have diarrhea, and because of the diarrhea, there will be electrolyte imbalance. So Crohn's disease, they will present with diarrhea. I don't know who can see this image very well, but in the GI system, I had shown this image before. Are we able to see the picture? I cannot share that with the computer, but the digestive tract, this is from the mouth down to the anus. Everything is affected. All your bowels are relaxed, so you start having diarrhea with Crohn's disease. So there'll be abdominal pain, diarrhea, and weight loss. And then there will be electrolyte imbalances, which will mainly cause hypokalemia, low calcium. There'll be depletion of calcium. Remember, there's diarrhea. So where there is diarrhea, you are concerned about calcium. So the food that you should avoid is dietary food like milk, dairy products, and high fiber meals, which may worsen the diarrhea. You don't want foods that will help increase the diarrhea. So Crohn's disease can lead to colon cancer. So for patients who have Crohn's disease, they can have colon cancer, and you cannot do surgery for that because it's like the whole GI tract is affected. So the treatment goal for this is drugs. Patient has to stay on drugs, and they have to work on nutrition to reduce the inflammation. So they have to know what to eat and what not to eat. Now, let's talk about Cushing syndrome. Cushing syndrome. So Cushing syndrome is a high production of hormones by the adrenal gland. When the adrenal gland produces too much hormone, that's glucocorticosteroids. The skin of the client or the patient that has Cushing syndrome will have fragile and bruising skin. They will easily be bruised. So if I rub myself against a hard surface, I can easily get bruises. So, and the skin is very fragile. So the client too gains weight. Cushing syndrome will cause weight gain. They will have weight gain. So the serum blood glucose level goes high. Patient will have high blood glucose. So you need to, their sodium level will also be checked. So they will have high glucose level and high sodium levels as well. So the serum potassium levels need to be high. It will either be high or low. So glucose will be high. They will have high levels of glucose or low levels of glucose, but their sodium level will be high. So potassium will either be high or low. So low, their calcium will also be low. Calcium low, sodium high, potassium either high or low, glucose either high or low. Take notice. And the treatment for Cushing syndrome is hyposectomy. Hyposect is a surgical procedure, and the patient has to continue for life on glucocorticoids. The patient has to take glucocorticoids medications for life. Let's look at cystic fibrosis. These are disease conditions that cause mucus production, or the exogland are affected. Exoglands are affected. These are typical anatomy and physiological topics that you need to go and write and study them. So if I'm mentioning them and you are not really getting everything about it, I'm not here to decide to start talking about start talking about the gland. I draw the anatomical gland of the exogland, and I explain to you how it is all processed. That is not going to save us time. Presumably, it is assumed you have all that, you had done that in school, and you are just learning to know the basics of what this condition is and what you need to know specific about these conditions. That's the purpose of what I'm doing. So in cystic fibrosis, the mucus producing or the exocrine glands are affected. That's the gland that is affected, the exocrine gland. Exocrine gland is affected. So cystic fibrosis, there is abnormally high mucus, and it usually becomes thick. The patient has a lot of mucus and it is sticky, and it can cause obstruction in the airway. Remember, cystic fibrosis usually affects the exocrine gland. So the two systems that are affected in cystic fibrosis is digestive and respiratory system. So in respiratory system, the mucus get trapped in the patient lungs. The mucus will be trapped in the patient lungs. And in the digestive system, the mucus will block the pancreas and the digestive enzymes. The enzymes that are secreted to help with digestion of food. So it will make it difficult for the intestines to be able to absorb nutrients. So nutrients absorption in the GI tract will be reduced. I wish I had done the GI system with you guys, but I did not do it, but I have that video on YouTube. Please look for the GI system to watch it. If you don't find it, let me know, I'll get it for you. So the most accurate test for cystic fibrosis is sweat test. They will do a sweat testing, and they have to check, when you start sweating, I don't know who has ever tasted his or her sweat, but I have tasted my sweat before and it's very salty. My sweat tastes a little salty. So the chloride level will be less than 60 milligram equivalent. So they usually do sweat testing for cystic fibrosis. So the other ways to diagnose cystic fibrosis will be chest x-ray. Remember, the airway was also involved, and it will be trapped in the lungs, and the mucus will be trapped in the lung. So when they do the chest x-ray, is also another form of diagnostic test for mucus, for cystic fibrosis. Then stool analysis, the patient's poop, and then they analyze the patient poop as well. Then we have the pulmonary function test that will be done in cystic fibrosis. So in cystic fibrosis, there's poor absorption of fat in the digestive tract. Remember, I said the GI system will be affected. So absorption of fat is also affected. So it causes steatorrhea. That's greasy, foul smelling, and pale stool. It's called steatorrhea. Let me type that and just share my screen again. So this is what I am talking about, if you didn't get it. So cystic fibrosis, yeah, I think that is the spelling, steatorrhea. This is what I'm talking about. So Absorption of fat will be a problem, and the patient will have steatorrhea. And steatorrhea means the patient's stool will be foul smelling, the color will look pale, and it has a greasy texture. So pancreatic enzymes should be given with each meal to help with the absorption of nutrients in the GI system. So they have to give the patient pancreatic enzymes. It is recommended to give the patient pancreatic enzymes which will help with absorption. The most appropriate diet for cystic fibrosis will be high calorie, high protein diet. So when you care for a patient with this problem, you need to understand the high calorie, high protein diet is recommended for such a patient with cystic fibrosis. Do we have any question at this point? Does anybody have questions? Another thing they will do for this patient, because it's GI and it's also respiratory system, they will also do postural drainage. Remember, it's mucus that causes the blockage in the exocrine gland. So you have to do postural drainage. And this is a common technique that is used to clear mucus, thick mucus from the lungs. So it is for preventing respiratory infection. You don't want it accumulating down there because it can cause an infection. Do we have any question? I'm going to talk about diabetes teaching, how you teach a patient who is a diabetic. So for a patient who is type 1 diabetes, type 2 diabetes mellitus, okay? If I ask you what kind of diabetes is usually well controlled by diet, that's the type 2. So a patient who has type 2 diabetes mellitus, it is well controlled by diet and exercise, not insulin. Type 1, they are controlled by using insulin. So diabetes type 2, diet and exercise will work for that patient. So a patient has diabetes type 2, you want to start thinking diet and exercise is good. Diabetes type 1, they need to take insulin. So what do you have to teach them about foot care for both of them? So you want to have them cut their toenails. They should cut their toenails across. They should cut it straight across. They should cut their toenails straight across. And then they need to inspect their feet daily for any sores on their feet. And then they need to keep their skin dry and clean at all times. Remember diabetic foot wound, right? It can lead to amputation. And when it leads to amputation with the amputated patient, I spoke a bit about it last time, you are worried about phantom limb pain. You are worried about phantom limb pain and infection immediately after the surgery. And then positioning, you elevate first 24 hours, you provide cold packs, after that warm packs after 24 hours. Please, I hope somebody remembered this when they give you a patient who has amputation. So mostly you teach them about foot care. They have to cut their nails across. They have to keep checking their feet every day for any wounds. Type 2 is best managed with diet and exercise. Type 1 is best managed with insulin. So if a diabetic patient vomits after taking pure anti-diabetic medications, you need to monitor their blood glucose. You need to monitor their blood sugar, and you do not repeat the medication as well. You do not repeat the medication. So the medication may have been absorbed a little bit. So if you give the patient glyburide, or you give the patient, what's the common one they take, and then the patient tell you, I just took the pill and I vomited. I took the pill like in 10 minutes time, I started vomiting. You don't have to repeat that pill, that medication, because part of it may have been absorbed. So you have to check their sugar. Is your sugar within normal limits? So if the patient's sugar is within normal limits, you're actually not worried. You try to manage the diabetes with less less invasive procedures, or you manage every patient with less invasive procedures before you move to complex stuff. Emilia, your hand is up. Do you have a question? Emilia, I see your hand is up. It's been up, but I just wanted to ask and I forgot. Okay, so you don't have a question. So you also want to advise a diabetic to have a yearly eye exam. They need to go for checkup in their eyes. Remember diabetic retinopathy. So they have to go and have their eyes checked on yearly basis. This will help prevent diabetic retinopathy, or in case it is about to happen, you'll be able to see it early. So what is insulin lipodystrophy? You know, when you keep injecting insulin at one place, right? It will cause lipodystrophy. So you teach them to rotate site of injection. So if I injected it on this shoulder or on this arm today, on this part of my arm today, tomorrow I move on this side. Or if I injected it one side, you can move to the other side, move to the other side. But when you just circle the one portion of your body, let's say your stomach, you portion one side of your stomach, I'm going to be giving it on the left side of my stomach. It can cause lipodystrophy. So you don't want to have skin complication. And this one, it causes a fatty mass, which will appear, and it make that place tender and harden. So that's lipodystrophy. So you want to teach them to circulate the area that they use to inject the insulin. So you also teach them, for those who take the insulin, especially type 1, they don't have to aspirate. When you are injecting insulin, it's subcu, it's subcutaneous. There is no need to aspirate before injecting insulin. So these are simple steps you need to understand. So the primary site for insulin injection is usually the abdomen, okay? The preferable site is usually the abdomen. So exercising, we all know, I had mentioned this in one of the days we met. I mentioned that when a patient do exercise, it will help lower the blood glucose. So exercising is good. That's why in type 2 diabetes, the best thing to help lower their glucose level is exercise. Exercise and diet will work for them. Now, alcohol, oral contraceptives, aspirin, alcohol, oral contraceptives will lower patient blood glucose. Okay, if a patient is alcoholic, they can have hypoglycemia quickly, very fast. Remember, the problem with alcoholics too is nutrition imbalance. You want to manage the nutrition imbalance. Vitamins, especially, okay? So for patients who have alcoholic problems, take notes. This is not what I'm talking about, but it just came to my mind. Take note, their problem is usually dietary imbalances or nutritional imbalance. You want to monitor they take vitamins. Usually they give them vitamins, and their complication can be pernicious anemia, vitamin B12. So infection, dehydration, stress, and surgical procedures, it can increase the patient's blood glucose. Remember, I mentioned aspirin, contraceptive, oral contraceptive, and alcohol will lower blood glucose. Exercise will also lower blood glucose. But a patient who has an infection, a patient who is dehydrated, a patient who is stressed, when you are under stress, or you underwent a surgical procedure, it can cause your blood glucose to increase. So what do you do, or what do you give to a patient who is hypoglycemic and is in a comatose state? Who knows this one? I think this one should be a question. So for a patient who is hypoglycemic, they brought a patient, family member rushed a patient with the ambulance to you and says, he's a diabetic, he just passed out, he's not responding. but I know he got his insulin this morning. He usually gets it once a day. He'd never have a problem with the sugar. And then you check the sugar and the sugar is like, let's say 40 or 30, and the patient is not responding. What will you give? Who knows that one? I don't think I should answer that.
Candy,
Huh?
candy.
I can hear you. Can you raise your volume high?
Like sugar candy.
The patient is not responding if I am alert. And another thing, please, for patients who are alert, you give them hard candy, okay? Don't choose questions that will tell you to give them apple juice. On the NCLEX, they want you to talk of hard candy. I see students make that mistake. They would rather choose apple juice because for one or two reasons, if you work in the facility, you see the patients that their sugar is a little low, they start giving them apple juice or orange juice to bring the sugar up, and then you go choosing that one. No, it's usually hard candy. So the patient in this case that I'm talking about, the patient is not conscious, it's not responding. So how will they swallow candy? What will you give? Who knows? The patient is not conscious, but the patient is not dead. Remember, the sugar is low, hypo. So who knows what you will give? You have to wake the patient up. It's something an LPN should know. Because I think I have only LPNs today.
Something under the tongue.
It's something you should know, because if the patient is already not responding, if the patient is responding, if the sugar is 40 and the patient is responding, it's good to give. But in this case, if the patient's sugar is even 50 and patient is not responsive, you have to give them glucagon. IV.
In fact, and is it IV or under the tongue?
Huh?
Is it going to be IV or under the tongue something?
I can't hear you.
I think
Your
my
volume
thing
is
is not
low.
clear.
You say
Yeah,
IV?
I don't know why. I was saying, is it IV or is it something under the tongue?
So you cannot give them under the tongue. Glucagon will given either IM or IV.
Okay.
It's either IM or IV. Under the tongue is no. Remember, the patient is unconscious, so you don't want to even put anything under their tongue at that time.
For airway.
You cannot, you don't have to go
thank
inside
you.
their mouth to put it under their tongue. So you give them glucagon via IV or IM, intramuscular, and it will wake them up. Then you can start managing them with their candy and all those things, but they have to be up first, up and responsive before they can take anything PO. Okay?
Okay.
Yeah. So we have some insulin pumps that will sometimes mimic the functions of the pancreas. So insulin pumps that are wearable and will always mimic the function of the pancreas. We know that the pancreas is the organ that helps secrete insulin. So we have patients that are on insulin pumps. They go home and they are on that insulin pump and they are monitoring them. So when you hang a patient, when you hang insulin for the patients, usually you can give the patient at a lower dose for 24 hours. If you remember one of our questions, I was discussing that for a patient who gets insulin or a patient who is diabetic ketoacidosis, usually they will give the patient a bolus of insulin and they hang it as an insulin pump. So if the patient is on insulin pump, it gives smaller doses of insulin. So it will mimic the function of the pancreas, because the pancreas does not release too much insulin. When it's too much insulin, that's why the patient go into hypo. Too much of it, the patient will go into hypo. So the pancreas tend to keep it at a fixed level for function. So the insulin that is used in the wearable insulin pump usually will be the regular or short-acting insulin. So the one that they will hang will always be a regular or short-acting insulin. So how often is the insertion site change when a patient is having an insulin pump? Who knows? The insertion site. So when the patient is getting an insulin pump, they have an insertion site, that the IV site that is given. You change the dressing for 2 to 3 days. Every 2 to 3 days, you change the site dressing, okay? So the insulin is delivered in continuous, intermittent, continuous and intermittent mode, continuous and intermittent mode. It's not a bolus. The bolus is what you give via IV pump. Usually that is if the sugar is too high. If the sugar is too low, there's no need for insulin at that point, okay? But this insulin that I'm talking about, given regular and short-acting, is when you want to bring the sugar down. Especially in the case of diabetic ketoacidosis, you hang the insulin pump. And the dressing site should be changed every 2 to 3 days. And also remember, every facility have a protocol. So when the NCLEX is asking you questions and they bring an answer option like facility, the nurse use the facility protocol to do this. And then you see the other options doesn't have a link with the answer or with what the problem that they are talking about. You have to choose the one that has the facility protocol, because remember, besides what is standard for nurses or what is standard for you to do within your scope of practice, the facility policy and protocols count in your care of the patient. So if the facility say we change our dressing every 2 days, you have to go by 2 days. We change our dressing every 4 days, and this is the reason we have the evidence to support it. You have to answer those things like that. Don't go and say the facility protocol, NCLEX doesn't have a facility. No, the patient that presented to you is in a facility, and you have to obey that particular facility protocol. So for a client, to advise a client who is wearing an insulin pump, you want to tell them to stop smoking or drinking alcohol. Tell them to stop smoking or drinking alcohol. So remember, for a patient that is not conscious, nothing by mouth, okay? You are worried they will choke. You have to give them IV or IM to wake them up. You have to give them glucagon. Glucagon, that's the one that will wake them up. But for a patient that is unconscious because you are suspecting that they have overdosed opioids, you have to give them Narcan. So don't confuse the glucagon for hypoglycemic patients and Narcan for opioid overdosed patients. So Narcan will wake the patient up. Glucagon will also wake the patient up, but one is as a result of hypoglycemia. You should have checked the patient's sugar and know that the patient is not responding because the sugar went low. When you check the patient's sugar, the patient's sugar is good, and you suspect the patient have taken some opioid because the patient is not awake to tell you that. That's why you give glucagon, because their sugar is not a problem because you have checked the sugar before. Any question at this point? Any question? We are going to take a break and then come back. Do we have a question? Anybody has a question? Okay, so we are going to take a break and we'll be back. Let's take a 10-minute break because I have to be off at 8 today. So we'll come back at 30. Is that fine? So that we'll have 30 more minutes to discuss. So we'll come back 7:30. Will that be fine?
Oh,
Yes.
Okay. So I'm going to pause the video. We're going to be back at 7:30. So see you then. You know, my recording. So remember that diuretics can either be given PO, IV, or intramuscular. So they are usually prescribed for patients with chronic heart failure, or patient with renal failure. Patient who has renal failure and has edema, they give them diuretics. A patient who also has fluid overload will be given diuretics to help reduce the fluid in the body. So the client that takes the diuretics, you have to teach them. They usually have to take it early in the morning. Early in the morning. Do you know why? Because the patient have to take diuretics in the morning because they have all day long to be awake and to be hanging around. So anytime they have to pee, they don't have to pee on themselves. So to prevent nocturia, you give the patient diuretics in the morning. So it is taken in the morning, all diuretics. That's the best thing to do. Now for a patient that came to you in a crisis around 1 p.m., you cannot say it's not morning, you cannot give it. If a patient came in and is having shortness of breath, has a history of congestive heart failure, and the doctor has ordered diuretics, you have to give it because you want the patient to be able to breathe normal, fluid overload. So taking it in the evening, the client will be going to the bathroom all night. You don't want that to happen. So what should you monitor for when a patient is getting diuretics? So you want to monitor them for low potassium. Remember, I said we have one that is potassium sparing. So you monitor the patient because the patient is urinating a lot. Apart from the potassium sparing, we have other types of diuretics you can give the patient. So you want to monitor patient potassium. You also want to monitor their sodium. They can have hyponatremia if they are taking diuretics. I don't know who has tasted urine before, but it also does taste salty. I happen to have tasted it just to be curious, not to drink it, but to be curious, to know how it is. So we have dehydration. So patients that get diuretics, they are at risk for dehydration. You want to take notice that they don't become dehydrated whilst they are taking, because remember, the purpose of you giving them the diuretics is to have them lose fluid out of their body. So weight loss is also another reason you have to monitor the patient. So for loop and thiazide diuretics, it will inhibit electrolytes such as potassium, sodium, and chloride. The patients that get loop diuretics or thiazide diuretics, it will have the patient remove potassium, sodium, and chloride. Apart from the potassium sparing, that will allow potassium in the body. You also want to monitor those patients' potassium so that they don't become hyper. Now, furosemide is a loop diuretic, okay? So mostly you always hear of furosemide, that's LACES, it's a loop diuretic. We have the thiazide diuretics, and these ones are contraindicated in clients who have sulfur allergies. So if a patient tells you, I'm allergic to sulfur, I'm allergic to sulfur product, the patient is not supposed to get a thiazide diuretics. If the diuretic is a thiazide, the patient is not supposed to get it. We have osmotic diuretics that is used to reduce intracranial pressure, and that you will see one medication, Osmitrol. Osmitrol. It's Osmitrol. Osmitrol. It's used to reduce intracranial. It's a diuretic for intracranial pressure for patients who have increased intracranial pressure. The Osmitrol will work out for them. So because the Osmitrol will decrease the intracranial pressure, it is used to also treat glaucoma, okay? It can be used to treat glaucoma. We know glaucoma is a problem with the eyes. And where there's increased intracranial pressure, we know the eyes will also be affected. The ocular system will be affected, or the eye system will be affected. So this is one medication that can be used for glaucoma, and it can be used as a diuretic to treat increased intracranial pressure. That's Osmitrol. Osmitrol. So take notice of that medication. Say the patient is getting, I have seen a question like that. I don't remember how the question was ever framed, but the question wanted to see if you understand that the patient that takes osmitrol asks you, I have glaucoma, can I take this medication? So remember that it's intracranial pressure medication, is a diuretic, but the patient can also get it. Now, mannitol will crystallize at room temperature. You will need a filter needle to draw up. Mannitol is one of the diuretics. You have to use a filter needle to be able to draw it, because in room temperature, it's going to freeze. It's going to crystallize. It becomes like crystals inside the bottle. We have the potassium diuretic, and that one we can talk about spironolactone. That is a potassium sparing diuretic. For those I send the pharmacology information to, it's a lot of information, but they are all grouped. If you take, let's say you get to cardiovascular system, I haven't been able to organize that, but it is well organized enough for your understanding. Just let me know if you are studying it and you don't understand it. I will explain to you how to study that to understand that pharmacology content I sent you. So let's say I started with allergy medication. So for those who I send that today, when you open that document, I started with allergy medication. I started with medications that are considered antihistamine. So antihistamines, what are their signs and their adverse effects? So you see what you're supposed to know about antihistamines. So what are the medications that are considered antihistamine? You will now see the medications of those that I have listed as antihistamines and what you take notice of when a patient is taking antihistamine. That was just my own way of summarizing the pharmacology for you. So if you get that document, please, it's a way to have you study your pharmacology. We know the medications are plenty, but get to know the few of what is around us to use. It's not every pharmacology that they'll give you all the medications. You don't need all the medications to pass the NCLEX. They'll give you some few. So have a general idea about what diuretics will do and you are fine. And have the understanding that we have potassium sparing diuretic and we have some diuretic that can treat intracranial pressure and can also treat the eye or glaucoma as well. So potassium sparing diuretics, the client is at risk for hyperkalemia. I think I had mentioned that one before. So if your client potassium is equal to 3 and Lasix and potassium sparing, that is spironolactone, that's aldactone, is being ordered, how will you proceed? So if a patient is, if a patient has an order of, the patient has the order that you should give the patient, let's say, Lasix, furosemide. We know that Lasix is a loop diuretic. I mentioned that. So the patient has an order for you to give the patient Lasix and also give them aldactone. Aldactone is also a potassium sparing medication. That's the spironolactone.
Are you feeling, my dear?
How will you give it? How will you give this medication? The patient potassium is 3. Patient potassium is 3.0. Is that normal in the first place? Hello?
No.
I'm asking a question. The patient has a potassium lab value. The patient blood work came back and the patient potassium is 3 or the patient potassium is 2.5. But you open the patient chart and you see that the doctor have ordered to give Lasix 40 milligrams IV push. And the doctor have also ordered to give the patient aldactone 20 milligrams. What will you do?
You hold the medication and call the doctor.
You hold which one?
The IV push.
Hold on. I think my computer volume has a problem because it's like everybody's phone is low for me, and I don't think it's everybody now. I think it's me. Let me see if I can bring the volume up. Yeah, my computer volume is low. Are you all able to hear me? Huh?
Yes.
Yeah.
Yeah.
Were you hearing me well? Because I just realized that the
Yeah.
volume was very low. Okay. The
Yeah,
volume
I
was
can hear you.
very,
Yeah,
very
Very
I
low.
can hear
well.
you. Yeah, I can hear you very well, but there's noise at the back.
Oh,
So I
yeah?
think it's not from you. It's
I
not
don't
from
think it's
you.
from me. I closed my
No,
door.
it's not
I
from
left them outside.
It's not from you.
Yeah. So me, I couldn't hear anything because my volume was very low. So it's like when you guys are answering, I'm not hearing anything. So it's now that I just realized that my volume has been low all this while. I'm so sorry about that. Okay, so I asked a question. I think somebody was answering. So the doctor have ordered these two medications. What will you do and why will you do that? Do you want me to say the question again?
Yes.
Yes, so the doctor have ordered Aldactone, right? Let's say Aldactone is 20 milligram. And the doctor have also ordered LACEs. But these are medications that before you give every medication, try to check the patient laboratory work. So you know blood work was done for the patient before. So before you give this medication, you want to view the patient chart. And you saw that the patient potassium was 2.5. What do you have to do with these two medications and why? We're talking about diuretics. And I've explained the various types. So what will you do with this medication?
I would hold the medication and inform the doctor of the patient's lab result because the potassium is already low. The potassium is already low. So given that medication would make it lower.
Okay. So the patient potassium is low. That's great. But coming to think of it, the patient has congestive heart failure or chronic heart failure. The patient is having this difficulty breathing because of fluid accumulation in the body. Or the patient is a renal patient and the patient has swelling all over. The blood pressure is sky high. You have to bring it down. But the potassium is low. What will you do? It's two diuretics, remember? I mentioned two diuretics. I said the doctor have ordered furosemide. So you need to know the class of diuretic furosemide is. And aldactone. Aldactone, you need to know which class of diuretic it is. Spironolactone. So that's where you'll be able to sort out the differences in notifying the doctor, because the doctor have probably ordered the medications before the potassium result came. But you who is about to give the medication, you decided to check the labs before you administer it. I see patients' hand up. Patients, what will you do and why? Patients, what will you do and why will you do that? Why will you take that step? Okay, so let me just chip in for the sake of our time, or somebody want to talk? So in explaining, I had mentioned that we have potassium sparing diuretics. Sparing, it spares potassium in the body. It does not pull it out. So the patient is peeing, but the potassium is not affected. The potassium channel in the body is not affected. So for a patient whose potassium is already low, you, the nurse, need to think that if the doctor have ordered two diuretics which one can be given with a low potassium and which one cannot be given with a low potassium. You're only contacting the doctor for the one that cannot be given with a low potassium, even though you need to report this lab value to the doctor. But remember, the doctor, you also have to treat both problems at the same time. Potassium is low, it has to be treated, that's all right. But you also need to be able to relieve the patient discomfort with the fluid accumulation right now. So furosemide is a loop diuretic. It's in the class of loop diuretics. So when you give furosemide, it's not going to help with the potassium. It's going to further lower potassium because furosemide will have the patient pee potassium out. The aldactone is a potassium sparing diuretic. So because the spironolactone is a potassium sparing diuretic, that one can be given. So you have the patient be peeing out the liquid or the fluid in the body, but the potassium is not reducing. It's sparing the potassium. Do we understand that concept?
Yes.
Yeah. So that's why I'm explaining the various types of the diuretics. Take notice of the potassium sparing one. It's not all the time you cannot give diuretics. So if they told you the patient potassium was 7.8, if the potassium was high, above normal, you cannot give the spironolactone. You cannot give the aldactone because potassium is high and it's going to further spare potassium in the body. It's going to cause more hyperkalemia. So the best option to have given if potassium was too high was furosemide, which is a loop diuretic, and will have the patient start peeing to reduce that one out. But if the potassium is low, you want to spare potassium whilst you have the patient urinate the fluid out. So that's the two options you want to take notice of. Do I make sense, please? Huh? So the last one I want to talk about is when a patient is getting a diuretic, you have to measure the fluid volume. You have to measure output. So ideally, depending on the patient's condition, you can have the patient on a Foley. The patient can have an indwelling Foley for you to measure the urine, okay? It's not part of the procedure for getting a clean catch, but if you have to take a clean catch urine sample, it's another procedure on its own, but you are just recording the amount of urine the patient is putting out in one day because they are on diuretics. Let's talk about, I'm moving far away to domestic violence. Domestic violence. What is the patient's sodium? What is the patient's sodium? What if the patient's sodium is low as well? Would we hold, I'm coming. Would we hold the furosemide? No, you will not hold the furosemide. Remember, when you are giving a patient diuretics, it's not like we don't have sodium sparing diuretics. So you are just being careful of the patient's lab result because there's a risk for dehydration and there's a risk for electrolyte loss in the body. That's why you monitor the sodium, you monitor the potassium, and you monitor for dehydration as well. So because the patient is losing fluid, that's why you're going to monitor. But it's not so specific that if potassium is low, you don't give diuretics. You have to monitor the patient. You have a sodium, not potassium. It's only potassium you are more careful about because that one comes with a lot of fluid coming out of the body. So remember, potassium works directly on the cardiac muscle. So because potassium works directly on the heart, you are more careful of that, even though you are worried about the other minerals in the body, electrolytes in the body, you're worried about the other electrolytes in the body. But for the sake of having the patients reduce all these things, remember a patient who already have fluid volume overload, the sodium will help them accumulate more fluid. So you're going to have them pee it out. You just want to make sure it's not too much of sodium. So you are monitoring all their lab results, but the only one that will determine which of the diuretics to give will be the potassium. whether it's high or low. Okay, it's not sodium. Sodium does not affect which of the diuretics you give. Can I move on now? Or any further question? Okay, so I am moving to domestic violence. And we all know that in America here, we have so many violences. When you come out of your house and you are not from a background that there is violence, you can, before you get to the supermarket, someone from somewhere will meet you and give you trouble unexpectedly. I'm not saying it happened every day. I'm not saying that's what happened, but these are unfortunate incidents. I'm just trying to talk about violence. But this is domestic violence. This is within. So this is frequently violence within your house, violence that is within you. So we have the domestic partner violence, you have the intimate partner violence, which is also a domestic violence where your significant other will be the one bullying you at home. So domestic violence, and we also have the children one. This is why we have a lot of children that go to foster homes out of the hands of their parents. So for a child who presents with a sign of domestic violence, you will see that the child will have bruises or burns on their skin. They'll be shrinking like creases, marks in their back when an adult approaches and then hitting others. So these are usually things that you will see on a patient that will make you suspect. Unusual things. So if you see me right now, you see things on my face like it's scratches, and it's like some are healing, others are not healing. They have different stages of healing. It's like you want to suspect violence. So if it's a child, you suspect violence. Mostly for some people, they'll be able to speak out for themselves. Elderly people and children are mostly at the vulnerable risk population to consider when it comes to violence. So the two factors that are displayed that play an important part in domestic violence are power and control. We have the abuser and the victim, okay? Abuser and the victim. So the power and control, the abuser has the power and sees the victim as a possession. So the abuser is the boss and sees the victim as, you are in my care, you are under me, I control you. So as for instance, you have somebody who is supposed to take care of their elderly mother, and they don't want to send the elderly mother to a nursing home for one or two reasons, but the elderly mother also has dementia and other problems that is a problem for them to manage. Then they start abusing the person. I'm just setting an example. So where you are the abuser, you are the one in control, you possess, or you are responsible for the victim, then you tend to be abusing the victim. That's the powers and control. So the abuser has the power and the abuser is in control. Those are the two factors that come into play when it comes to domestic violence. Because of the society that we live, the NCLEX will always present to you questions under domestic violence because they want you to be able to identify and report them. You have to be a reporter. Every healthcare worker is a mandatory reporter when it comes to your attention. So what are the signs of neglect in children? So they'll be stealing food. For children who have a sense of neglect, will be stealing food. They'll have lack of dental care. So when the NCLEX present to you and say the child has lack of dental care and their mouth is smelling and blah, 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 they don't look well kept, they are unkept. You want to question any form of abuse. So they have poor hygiene, poor schooling attendance. They can give you a question as if you were a school nurse as well. And they get scared. They are easily scared of people. They are not approachable. So when a victim of rape show no emotions or feelings after an attack, we call that one a controlled response. It's a controlled response. You know, we have violence that is also part of sexual abuse. We also have sexual abuse. Now, for this particular moment we are in now, for the sake of the NCLEX, they can give you a question, usually when they talk of sexual abuse, before, or let me not go into detail with this, we always think it's women or it's ladies who come with sexual abuse or sexual violence. You can have a man come to you as a rape victim. So take notice. You can have a man come to you as a rape victim. We have the LGBT community right now, and then you can have one person come to you and say, oh, I have my male partner, I'm a gay, my male partner is sexually abusing me. So take notice of answering questions like this. When it comes to sexual abuse, it's no longer only for ladies. It's not only ladies that are sexually abused. Everybody can be sexually abused. So for sexual abuse people, some people are able to control it, others cannot. They come to you and it's all crying and crying and crying. They cannot control the feeling of being sexually abused. So take notice of that. We call that one the control pattern response. They're able to control what they're feeling within them. And if a patient is presented to you as part of sexually abused, you don't want to wash them. You don't want them to go to the cleanup. You don't tell them, give me urine. You don't take urine sample. Urine sample, they have to get evidence from the person. They have to get evidence of everything that happened. You have to check and do vaginal exam to see if there's bleeding, or if it's a man, you have to do perineal exam to see if there's any bruising, any bleeding, any discharges. You want to know all these things. That is for sexual abuse. Remember, it's all counted under violence. So that's why I'm just going into all of that. So the stages of domestic violence in an intimate partner relationship is called the honeymoon stage. We have the build of stress stage. We have the anger stage. We have the beating, and then reconciliation stage. So domestic or intimate partner violence. Intimate partner violence, which is a form of domestic violence I have mentioned. So we have them in stages. We have the honeymoon stage. We have the build-up stage, the build of stress. So even though the person is your partner, you started by loving the person, and at a point you are just trying to build up the stress. You're trying to accommodate because of the love you might have for the person. But at a point, the abuser start developing some kind of anger, and it's like, I just need to attack. I just need to face this. Then they start beating up. Where it comes to a man and a woman, mostly we would think it's the man who is always beating the woman. But in this modern generation, women can be the beater. A woman can be the abuser. Okay, so don't think it's only men who abuse. We have strong women who can beat spa. And we have the reconciliation phase. Because I even watched a movie like that. And the woman was like, every day he'll beat the husband, and then he come out and he's the happiest woman. The day he beat the husband, that's the day he gets more energy. He's the happiest one coming out to do everything she wants. The day she don't beat the husband, she feels sick. So the generation have changed. We have the super strong women who can beat men, regardless of the size of the man. They are just...
Can I get a title of the movie?
Do you think I remember? I watch a lot of movies, but I don't put it in my mind. When I finish watching the movie, I just get out and I'm done. It's not something, but I can try searching. I'll try searching it. If I get it, I'll tell you. Listen, we have it. It's common. Okay. Okay. So a rape victim should not take a shower. Somebody who has been raped should not take a shower. And you want to take notice of that. Okay. So for a sexual For a sexual abuse that is from a family member, if you have ever seen it, you have somebody come to you and say, my uncle slept with me. We call that incest. Incest. Traditionally, they'll tell you it's prohibited, it's never done. Now, let me just chip this in. How do you wear sterile gloves? If they give you this question as a drag and drop, how will you don sterile gloves? Another thing I want you to go and learn is how you perform, how you wear your PPE for I think standard precautions. Go and learn that. Next time when we come, I'll have you all tell me how you put on your standard PPE protocol. Those things will come as drag and drop. Those things will come as drag and drop questions. Okay? They wouldn't want to, they don't give most of those simple procedures that you don't expect. They can ask you, how do you check a finger stick glucose, blood glucose on a patient? And they give you 5 steps. They want you to arrange them in order. So they come as drag and drop, simple procedures. Those ones will usually be procedures that you can delegate to somebody, but they will still ask you to do them. So how do you don a sterile glove? I think I should jump that one and talk of something else so that we'll go and look for it. I think my time is actually up. But before I go, let me talk about epiglottitis. Epiglottitis. I'll just talk about this one and then we can hang up. So epiglottitis is the lack of skin up to the base of the tongue. You know, we have the epiglottitis at the base of at the back of our tongue when you open your mouth. So it helps in opening and closure around that side, and it also helps with respirations. So the epiglottis is at the back of our tongue, and it usually helps in opening and closing our mouth and also during respirations. So inflammation of the epiglottis is usually the epiglottitis, when the epiglottis become inflamed. So usually this is also, it can also be a viral infection. So when a patient has flu, Haemophilus influenza, so the cause of epiglottitis is usually Haemophilus influenza. So remember, it's a bacteria. It's either, it can be a viral or a bacterial infection. But remember, I just mentioned that it's at the back of the tongue. It helps with opening and closing our mouths, and it helps with respirations. So when this epiglottis is inflamed or is diseased, if I am you right now, I should have started thinking of what can happen to the patient. Opening, closing, and breathing. So you can already figure out the signs and symptoms a patient will present. So the usual age of people who get this are usually children, mostly 2 to 5 years old. They will have this epiglottitis as a problem. And because it controls closing and opening and breathing, the child can have dysphagia, difficulty swallowing, they'll be drooling, and then voice loss. They will not be able to speak because it controls the opening and closing. So these are common symptoms in a child that you will expect. So when you see them drooling and the saliva is coming out of their mouth, or any patient at all you ever assess and you see drooling, you want to be worried about the airway next because they can choke. So during an episode of epiglottitis, you want to encourage them to be in a sitting up position. You want to have the child in a sitting up position and tongue protruding with drooling and shallow respiratory rate. So this is what the child will look like. The child will be sitting up, which is fine because it will help with the air exchange. It will not have the child laying back and the things go back into the throat and cause more choking. But you see the child sitting up. The child will sit upright. For a child who has epiglottitis, sitting upright Mostly NCLEX will not present to you as epiglottitis. They can say a child has epiglottitis. Which of the following actions will you do first? That's fine. That is if they want to go basic with you. But they can say you are the nurse on the floor in the pediatric unit. You have been floated down to the pediatric unit. You walk past a mother and a child sitting down, and the child is sitting upright, protruding the tongue. And when you assess the child, you notice the child has a respiration off. You understand? They're not going to tell you it's shallow respirations. They're going to tell you the chest intercostal was retractable, and they tell you that the respiratory rate was 11 or 9 or 10, a little below the normal. And then they tell you the breathing was a little rapid or slow. They want you to be able to figure out the prominent signs of epiglottitis when you see a child. So you see the child sitting upright, they will protrude their tongue and they are drooling, and saliva is dropping out of their mouth as if the child is mentally not sound. So they'll be drooling, they'll have problem with swallowing, and they'll have rapid respiration. So epiglottitis cannot be treated at home. It's not a problem that you can have it treated at home. So the child must go to the hospital. It's an emergency. The child has to be seen as soon as possible. Remember, airway is involved. So you never also put anything in the child's mouth to assess the child. So when you see this is not the time to use a tongue depressor and you are pushing on the tongue to look inside the tongue. The symptoms, you need to know. If you understand what it is and you see drooling coming out, the child is sitting upright and breathing fast with shallow respirations, you don't want to do that. So usually if the child cannot breathe and it's that much severe, intubation will be the recommended treatment, the intubation to help save body organs. Now take note, the purpose of intubating a patient is to have the patient other body organs get oxygen supply while they try to treat the underlying cause of the patient's respiratory failure issues. So it's to have the entire body get oxygen supply. Now they give antibiotics. So remember, if all that is inflamed and is bacteria or viral, you want to treat with antibiotic therapy. So you also, at that time, you can avoid the epiglottitis. That's why it is good to give them antibiotics. It is good to give flu vaccine. So children are recommended to take immunizations. So how do you wear sterile gloves? How do you wear sterile gloves? So first of all, you want to gather all your supplies that you need. You are in the surgical unit. You are going to assist with a laparostomy procedure. You are going to assist as a circulatory nurse in a laparostomy procedure that is going to be carried out. What is the procedure that you use to don on your sterile gloves? Drag and drop. So you want to wash hands and you dry them first because it's sterile. Remember, it's not surgical gloves where you just grab it and pull your hand inside. No, even with that one, it is recommended you do hand washing first. At least even, what's the name? Hand sanitizer, you can use that. But for a surgical procedure or for a sterile glove, you gather all your equipment that you need to don the gloves, which is mostly the gloves in a sterile environment. And then first of all, you want to wash your hands and you dry your hands. Then you place the pack on dry waist high surface. So you put it at your waist level. Don't put it above or under below where you will bend down. You don't scoop over a sterile field. So if this area is sterile, you don't have to bend down over this way. So you don't bend over a sterile surface. So it should be at your waist level. So you open the package using outer 1 inch margin facing gloves towards you. So you want to face the gloves, the side of the gloves that your hands will go in towards yourself. So with your 2 fingers on non-dominant hand, so this is my dominant hand. My right hand is my dominant hand. This is my my non-dominant hand. This is my dominant, non-dominant hand. So you want to use your 2 fingers. You want to use at least your 2 fingers from there. And then you pick up the calf of first glove. So, you know, when you have the sterile gloves, it will also be inverted. They always, at the end, they'll turn it upside down. So you don't want to touch where the finger part is. So you're going to put this, you use 2 fingers, you pick it up, and then you try putting your hand inside it. So you you place the glove on dominant hand. Now you are going to use the non-dominant one because you have to don the dominant hand first. So you use this hand and you pick it up like this. So assuming this is my sterile glove, I use this one and then I use 2 fingers to pick it. So I pick it like this and then I push this clean hand inside of this. Because I'm using this hand. This is my dominant hand or dominant hand. So that's the hand I will wear first. But I have to use this one to hold the glove with 2 fingers and then I slide my hand inside. Then you place the non-dominant hand on the glove, making sure not to touch the outside of the glove. So both hands gloved together, only sterile area to adjust for your comfort. So now that you have put your hands inside both of them, you can now adjust both sides of the gloves because they are both now sterile. You don't want to use this to now touch something outside of the non-sterile field. So that is how you don your gloves. You use the non-dominant hand first, you pick it up with this, and then you use the dominant hand, you push it inside, and then you use this one to hold it at the bottom, and then you lift it up. That's the one that has the gloves with a clean hand. Then you slide the non-dominant hand inside. Now you can use both hands to adjust this one and adjust this one if it was now well adjusted. That is how you wear your gloves. On this note, can we call it a day for today? Do we have a question? Anybody has a question? Hello, are we on? Anybody has a question?
No.
Okay. So I did send out the assignments today. I know last week we jumped a week with the questions, but it's okay. So I did send out the assignment and I had somebody, I did send out the assignment today. So please attend to it and let me know. If not, on this note, we are done for today. I'm going to pause.